Hello, my name's Nick Oliver, and I'm going to talk about do-it-yourself diabetes technology from a publication perspective. I work in Northwest London in the United Kingdom. I work at Imperial College London, and I'm a specialist in type 1 diabetes, and in particular how we apply technologies for people living with type 1 diabetes to improve outcomes and quality of life. So these are my declarations of interest, and I'll leave them there for a couple of seconds for you to read. So today, in the next 20 minutes or so, I will try to talk about the challenges of do-it-yourself academic dissemination. And in particular, we'll think about evidence quality and quantity. We'll think about study design, some of the issues around data ownership and data funding, and I'll review some of the alternative approaches to data publication, including citizen science and real-world evidence generation. So what qualifies me to talk about this? Well, hopefully a little, and I'm looking forward to the discussion afterwards and hopefully some challenging questions. So at the moment, I'm an editorial board member for Diabetes Technology and Therapeutics, and I've been reviews editor at Diabetic Medicine since 2017. I'm very honoured and privileged to say that from January of next year, 2021, I take over as editor-in-chief of Diabetic Medicine. And as I said earlier, I'm an academic clinician, so I do my own research and I publish my own data. So I have a track record of publication, and I focus on type 1 diabetes and how we apply technologies. So hopefully my expertise is relevant to DIY diabetes technology. And some of you may have seen that earlier this year, or perhaps late last year, I can't quite remember now, I published a piece in Nature Digital Medicine talking about some of the challenges of DIY technologies for people living with type 1 diabetes and how we move from something that is used off-label into something that can be used by more people and is more readily accessible and available. I'd be delighted to share that with you if you'd like it. So to start with, and just to illustrate a point, I'd like to talk about two different papers that have been published in the last couple of years on diabetes technology. And for the sake of initial anonymization, I'm going to call them paper 1 and paper 2. So these are both published, they're both in the public domain, and they're both published in peer-reviewed journals. So paper 1 is a paper that looked at 558 adults and children with type 1 diabetes. The mean age was 23 years with a standard deviation of 16 years. 57% of them were female, 91% were white, and as is common in type 1 diabetes populations, the BMI was slightly above 25, so slightly above the overweight threshold. Baseline HbA1c in the study was 6.8%, which is 50 in millimoles per mole, and this was a study with a 6-month follow-up period. Really importantly, it included people with severe hypoglycemia, and I think that's particularly important because including people at highest risk in these studies is critical to see outcomes in those people with the most challenging diabetes. And this was a prospective observational study. It showed that there were significant improvements in hemoglobin A1c, time in range, and time below range. Paper 2 is very similar. So it had a smaller population of 124, and it was adults only. Because it was adults only, it had a slightly higher mean age with the same standard deviation of age and exactly the same proportion of men and women. Baseline HbA1c was slightly higher, but again, it was a 6-month follow-up study, and this study excluded people at highest risk of severe hypoglycemia, so only really told us about people with overall glucose that was close to target without challenging hypoglycemia. Again, it was a prospective observational study, and because of its nature, there were no p-values provided in any of the results. It was simply before and after with no attempt to look at significance. So on the face of it, reasonably similar studies. One had greater power to detect changes and showed some significant improvements. One didn't do that. One included children and severe hypoglycemia, and one didn't. But overall, they're not particularly different papers in some ways. And really importantly, I should say, the intervention in both of these studies, sorry, I should have said this earlier, the intervention in both of these studies was automated insulin delivery. So a closed loop and artificial pancreas system using a sensor, an algorithm, and a pump to optimize glucose in people with type 1 diabetes. So let's look a little bit more at the papers and see if we can work out any differences. So the one on the left was a review of Loop and was published in Diabetes Technology and Therapeutics, which has an impact factor of 4.4. So very good for a diabetes technology journal. And the one on the paper on the right, remember, smaller, no p-values, was a study of the Medtronic 670G system and was published in JAMA with an impact factor of 45.5. Just in case, I'm sure you will know this, but impact factors are essentially a measure of how papers in a journal are cited and the number of times they're cited and the quality of the journal they're cited in. So they are a proxy for the overall quality of the journal and how much of an impact that journal makes in its field. JAMA is huge, so JAMA's alongside New England Journal, Lancet, those sorts of things. So very high impact. So we can see some difference here in how these two papers have been handled at an author point of view, at a submission point of view, and potentially in an editorial point of view. And I'm not criticizing or suggesting that either of those publication strategies are incorrect, but I do think it's striking that there are some really significant differences there. It's also important that I say that the paper 2 in JAMA was not published as a full paper, it was published as a research letter, but nonetheless it was accepted in JAMA, whereas the paper on the left was accepted in a journal that has an impact factor that is 10 times lower. So the phrase parity of esteem is used sometimes, and that phrase is really used to refer to mental health and physical health, and the idea that mental health should have parity of esteem with physical health when we're talking about long-term conditions and other things. So I don't want to hijack that phrase, but there is something here about parity between the left, which is of course a DIY diabetes technology, and the right, which is funded and manufactured and run by Medtronic. So let me explore some of those things and see if there are some things that we can do differently as a community, both as academics and as editors on journals and as people with diabetes working on DIY solutions. So if we go back to PubMed, which is the large repository of all papers published over the last, ever really, and we do two different searches. So the top search is simply artificial pancreas, and we do that in PubMed. We get 1,755 papers, and you can see that they stretch back as far as 1948, with a real peak coming in the last sort of 10, 15 years or so. And it's important to say this includes a lot of technical studies. So a lot of these will be human data, but a lot of them also are technical studies, algorithms, in silico studies that are published in similar journals. And then we do a similar search for DIY diabetes. We find 38 papers, and the earliest of those is in 2008. Now, these aren't exhaustive searches, but I think they're illustrative that there is a significant balance shift here in how we publish things. So if you have artificial pancreas, and a lot of those papers will be academic, they'll be peer funded, so they'll be charity funded or NIH or NIHR or similar sort of funding streams. They'll be written and published by well-known groups in the field, and they will be published in a reasonably small number of journals. So the majority of these will be in Diabetes Technology and Therapeutics, Journal of Diabetes Science and Technology, and some other diabetes journals. And then we look at the bottom ones, DIY diabetes, and of course this might reflect submission, not just acceptance, but it might reflect that only 38 papers have been submitted, in which case it's 100% publication rate. But there is certainly some disparity there in how many papers we see for the different approaches. So what are the considerations from an editorial point of view? So if you are sitting working with a journal to try to publish the best papers you can, the highest quality that will be cited the most, what are the things that you consider? So the first thing that an editor will do when they see a manuscript come to their journal is think, does this fit with our scope? So if you work in a diabetes journal and you receive a manuscript that is wholly about rheumatology, it doesn't fit in scope, and you will click the reject button very quickly, and that's a very straightforward rejection decision. Some of the other papers sit right on the cusp. So if you take diabetic medicine as the example, historically we have been a clinical science journal only. So we only accept papers that have been with science undertaken in humans. So we don't accept animal studies and we don't accept benchtop studies. But of course, there are some of those studies that are really on the cusp. So if you take a study in a small number of people with an exploratory biomarker and then some laboratory science that shows how you measure that biomarker, is that clinical science or is that basic science? And the answer to that is it's up to the editor, but it's important to think when you submit a paper that you go to the journal website and have a quick look through the scope to make sure that what you're doing is submitting a manuscript to the right journal so that it will immediately pass through that. The second thing is to think about journal style. Does the manuscript fit the journal? So again, if we think about diabetic medicine, it has a style and it has a unique identity, and a lot of the things that it has published, and this is mostly because of my predecessor Richard Holt, who's been fantastic at building this, it publishes a lot of psychosocial and qualitative research in diabetes, ensuring that the quality is high, but that is one of the things that it has become very strong at. It has a very strong associate editorship in that, and it means that if you're writing that sort of paper, you might well look around and think, well, actually diabetic medicine is the natural home for that, and it fits the journal style. Leading on from that, it means that it will fit the readership. So readership has changed quite significantly over the last few years, because what used to happen is that you would get the journal through your letterbox at home or at work, and if you didn't get it, you'd have to go down to the library and dig out the right issue of that journal, and it meant that you had a very strong readership, in the same way that some people will always read the same paper on Saturday or Sunday. Sometimes people will always read the same journal. But of course, now that we've moved almost entirely away from paper printed journals, it means that people can have far more journals that come to them, because you can have the table of contents emailed to you every week or every month. And it means that your readership is wider in terms of the number of people who will receive your table of contents, but it may be narrower as people don't always look through those tables of contents. So readership is slightly different, but again, if you have a journal style and a certain, that will mean that a certain group of people might be interested in a journal, and that will define your readership. You then need to think about the sticky people, the reviewers. Are they going to like it? So most journals will send most manuscripts to 3 reviewers as a minimum, and those reviewers will be experts in the field, and they might be your friends, or they might not be your friends. You can sometimes with journals tick a box that says, I would like these people to review my manuscript, and sometimes editors will send your manuscript to those reviewers, and sometimes they won't. Sometimes there are boxes to tick where you say, I do not wish this person to review my paper. And if there's one person that I will generally always send a paper to, it's the person who you don't want to see it, because they're likely to have a strong opinion. It's opinion that you can ignore, but if there's someone you really don't want to see your paper, there's a reason for that. And as an editor, you might think, I'd like to know that reason. I'd like to understand what the issue is here. You don't always take notice of that. But in general, as an author, I wouldn't put people in there in the category of not wanting to see your paper. The next thing that an editor needs to know is, will this paper be cited? So unfortunately, the reality is that we're not just trying to publish interesting things, we're trying to publish things that will be of interest and will also be cited by future papers. So there is always one eye on the fact that this is going to be used by other scientists in the future. And it's impossible to know that, of course. There are some very interesting statistics about this, and actually lots of papers don't get cited. If you take a very high impact journal like Nature, a significant proportion of their manuscripts will never be cited. But the ones that are cited so many times and in such high impact publications that it serves the Nature journal very well, and it means that their impact factor remains very high. So it's important to think, how do I make my paper interesting and suitable for future citations? So when you're writing it, think, how does this guide future research? How will this be cited for future research? And similarly, therefore, does it help the reviewer, does it help the editor, sorry, to drive the impact factor of their journal upwards? And finally, there's a question here of income, and I'm sorry to bring funding into this, but it's important. Journals need to make a degree of profit. So therefore, does a manuscript generate revenue? And there's several ways that a manuscript can do that. So reprints can generate revenue, open access publication can generate revenue, and there's different models of open access and different ways to fund that publication. But for example, if you are to publish something from an industry, from a commercial entity, so if you were to publish something from a pharmaceutical company that showed their drug in a very flattering light, they might want to pay the journal so this is open access so that everybody can access this piece of work. But don't forget this other thing. Editors can and often will be wrong, so don't be disheartened by their decision. This is the letter to Hans Krebs, telling him that Nature did not wish to publish the Krebs cycle in 1937. They very kindly said that if Mr. Krebs didn't mind a delay, they would publish as a letter at a later date, but Hans Krebs decided that he didn't wish to wait for Nature and went and published the Krebs cycle somewhere else. And I have no idea how many times the Krebs cycle has subsequently been cited, but I should imagine it's quite highly cited and has quite a high impact. So editors can be wrong. You can do something brilliant and really strong that you're very pleased with, and it can be turned down, and it can be very important. So don't be disheartened and don't assume that the editor or the editorial team are always correct. They won't be, and this is always true. Of course, there was the famous story that the Beatles were rejected by a record label as well. And I'm sure there are lots of very similar stories of papers that have been rejected. So when we think about DIY diabetes technology, we have to think about evidence quality and quantity and how we optimize that publication. So by its very nature, this is mostly limited to real-world data, which means it's selective and often self-selected cohorts of people living with type 1 diabetes, which means that there is an inherent risk of bias and confounding as it's non-randomized. Now, it'd be lovely to be able to do a randomized study, and of course that may be possible in due course, or there may be one already happening that I'm not aware of. But so far to date, most of the data have been selective and in selective cohorts. So that is challenging, and I'll come back to how we might think about ways around that and ways to talk about that. The second thing is about clinical effective considerations. So as you saw earlier when I showed you the two papers, if you were looking at a population that has a baseline HbA1c of 6.8% or 50 millimoles per mole, what is the clinical effectiveness that you're looking at? HbA1c is not a particularly important outcome if everyone at baseline has an HbA1c that is very close to target already. And of course, it's also very difficult to further reduce HbA1c from 6.8% and a change to 6.7%, while it may be very pleasing to see, is unlikely to be statistically significant or be relevant for cost effectiveness. So not only do we need to think about which outcome, we need to think about who we're doing it in, and we need to think about what we're comparing it to. So it's fine to do before and after studies, but if you are going to do a before and after study, then you need to think about ensuring that you've recruited people in whom you can show a difference, because otherwise you will not be able to show cost effectiveness, and that's going to be a very important outcome here, because it's not just clinical effectiveness that we want to show, but cost effectiveness too. One of the other challenges with DIY diabetes technology is that everyone owns their own data, which means that as a group and as a collaborative, it's unclear who owns that data and unclear who has rights to authorship. Now, I'm very aware that there are ways to address that, and I'm very aware that there are projects ongoing where people contribute their data for free for researchers to be able to work on. But again, that comes back to the first point, that if you are only taking data from people who elect to contribute their data, there is inevitable risk of bias and confounding, as you have a significant self-selective cohort. And this goes round and is an inherent weakness in some of this research, but it is something that can be addressed. And finally, because DIY diabetes technology is by its very nature DIY, it's unclear how funding for analysis and publication can be met, though again, I know that there are peer-reviewed funding opportunities and peer-reviewed funding collaboratives that are working on this and will be able to address this issue. But they're just all things to think about as you go through publishing DIY diabetes technology work. So what are the alternative approaches? Well, one of the things that has been incredibly important this year is citizen science. And I'm very pleased that I've gone this far through my talk without saying COVID, but I am now going to have to say COVID, I'm afraid. So coronavirus has created challenges, but it's also created huge opportunities, both in clinical medicine and in academic work and in research. And the REACT study, which is at Imperial, so my declaration of interest is that this is in my own institution. The REACT study has sent packs out to people in the population and has asked them to do home testing and fill out data questionnaires, and has by doing so collected hundreds of thousands, if not millions, of data points for the general population, which has then been able to publish at regular intervals. And the REACT study is publishing so frequently that there's very little actually that's already into peer review, but is all in preprint. But it has created huge amounts of impact. It's been on the radio, been on the television, been in the newspapers, and will undoubtedly lead to high impact peer-reviewed publications in due course. It is by its very nature selective and self-selective because it only includes people who will put their hand up to do this work. But because it's in a large number of people, and because it's prospective and observational in those same people, it gets over those problems by having large numbers. So it is possible to leverage citizen science, and it's possible to do so in a way that is high impact. But it has required numbers, and because of the high numbers, it's required a reasonable amount of money. And this has been NIHR, so that in the UK we have the National Institutes for Health Research, which is a public body funding clinical research, and the NIHR have funded this work. So it's by no means free, but it is fairly DIY, and it is in large numbers of people, and it is citizen science. And it has led to high impact. So looking at that model of how that's happened in a systematic, robust, structured fashion is a very interesting way to look at how to undertake citizen science successfully. What they've been able to do is focus on the strengths of the data. So if you take the REACT study, or if you take DIY diabetes technology, you have a large pool of people. It's then about trying to leverage as many of those people as possible and being clear, systematic, and robust about it. So if you said that, if you describe DIY diabetes technology research as an ad hoc audit with random data collection from a group of highly selective people, it's unlikely to have high impact or be published. If you describe it as a prospective observational study of a heterogeneous group of people in the real world, then you might suddenly get a higher impact. So some of this is simply about using language in the right way to describe your data in a way that sounds and is robust and systematic. And I'll come back to a little bit about that in a second. So one of the lovely things about having a selective group who are self-selective is that you will have sub-analyses of groups of interest. So as I said earlier, applying automated insulin delivery to people who don't have severe hypoglycemia, who already have an HbA1c close to target, is unlikely to show outcomes of interest. From a biochemical point of view, I'm very clear and understand that there are issues around quality of life and burden, and again, those are important and I'll come back to them. But we're unlikely to show biochemical or biomarker outcomes that are statistically or clinically significant. But there are groups here who are at high risk of severe hypoglycemia, those with previous DKA, and people with active complications who would ordinarily be excluded from Medtronic study, for example. And those sub-analyses are therefore of much higher impact and much higher interest because they haven't otherwise been done and they haven't otherwise been looked at. One of the other things that we have in the diabetes technology, DIY diabetes technology cohorts, is that we have a longer duration of follow-up. So any clinical study that is undertaken prospectively for an outcome has a stop date. whereas DIY technology doesn't necessarily. It has a longer start date from a long time ago, and it doesn't necessarily have a stop date because people continue to use it. And that means that as long as the data collection is systematic and robust and prospective, we have much longer follow-up, and we are able to leverage that longer follow-up to show maintenance and sustainable outcomes. One of the most important things about the data collection is that it's systematic. It's clearly described, it's robust, and it has equally applied standards throughout. So the difference between an ad hoc audit with people submitting data in different formats in different ways at different times isn't really acceptable for publication, but systematic data with clear data cuts and data cleaning and a clear way of handling missing data is really important to show that your real world data are as robust as anything else. And of course, I'm not going to talk about these because others will talk about them. It's important to address barriers when you're talking about DIY diabetes technology. Everyone is cautious about risk, certainly in your readership. If you wish to publish in a peer-reviewed journal, everyone is cautious about risk, and everyone will be cautious about the medical legal framework. So rather than wait for reviewers to raise those issues and to raise them as problems, address them, talk about them in the discussion, and make sure that when reviewers come to read through, they accept very clearly that the limitations and those two issues have been addressed in a way that is absolutely clear and open. So what about real world evidence? So there is a lovely quote that I saw from the UK government actually that said science can move faster than systems, and of course it can. But what this means is that real world evidence can sometimes be much more effective than using randomized controlled trials and the slower regulatory processes that we've been using for so long. So what that means is that real world evidence has been established for pharmacovigilance, so that we have the yellow card system where you can declare adverse events in real time, and that's real world data, and that contributes to the pharmacovigilance for new and well established pharmacotherapies. That can increase the speed and lower cost of clinical studies, particularly post-marketing clinical studies. So using real-world evidence has already been acknowledged to be faster and of lower cost, and actually is actively encouraged by the MHRA in the UK, and I think also by the EMA in Europe. So real-world evidence is becoming increasingly important and is acknowledged to be a powerful tool. Really interestingly, the FDA in the USA, the Food and Drug Administration, has published guidance for use of real-world evidence to support regulatory decision-making for medical devices. So not only is this about post-marketing vigilance and adverse event reporting, this was to support the actual regulatory decision-making. So the regulators are moving in this direction and mirroring their language, and the language that are in these documents is really important for when we publish, so that we can say that we are using the guidance from the FDA and reference the guidance from the FDA in data collection. And that is a very nice way to show that the author, to show the editor, the reviewer, and the reader that the data are really robust. And a lovely example of this, and I know it's in pharmacology, not in devices, is the Salford lung study. So this was undertaken in Salford, which is in northwest England. So it was a hybrid study. So it was a randomized controlled trial of a pre-licensed medication, but all of the data were taken from a real world system. So participants were recruited and randomized to different therapies, but from that point onwards, all of the data were collected through routine primary care systems. So yes, it wasn't necessarily a cheap study to do, but it was all real world. So this led to high impact publications and was sponsored by GlaxoSmithKline. So what are the differences then between real world evidence and audit? So there are inclusion and exclusion criteria to real world evidence, a documented consent process, protocolized systematic data collection and recording and real world evidence, and it must be hypothesis driven with predefined outcomes and an a priori analysis plan with appropriate data monitoring. And if you have all of those things in your real world data, it suddenly becomes a much more robust proposition for publication, and it suddenly becomes something that editors and reviewers and readers will be much more interested to see. And it's a way to try to drive that parity of esteem, or that disparity of esteem, to be a much smaller gap. So finally, a couple of very short points to make. This is in the red box here. This is the paper written by Crick and Watson, which describes the structure for DNA. This is the first description of the structure for DNA, and it's 843 words. If Crick and Watson can describe the double helix in those few words, I'm sure we can describe some diabetes technologies in few words. So be brief and be clear. You don't need to write 3,000 words just because the journal will accept 3,000 words. If it's 1,800, that's fantastic. So keep it brief and keep it clear. And finally, when you think about the parity of DIY research, think about all of the drivers and all of those other factors that will impinge on the likelihood of publication. And that includes reviewers, editors, funders, quality and quantity of evidence, the author esteem, which I'm afraid is still an issue. There are ways to address it. So there's things that some journals will have anonymous authors and named reviewers, but nonetheless, author esteem remains an issue. The quality of your findings, and of course the quality of your writing. And if you write clearly, robustly and systematically, that will help enormously. So to summarize, optimize what you already have in place and be systematic and rigorous with it, especially with real world data, and do so in line with the international guidance. Consider and cite the existing literature that uses similar approaches. So just because it's not diabetes doesn't mean to say that you shouldn't cite the Salford lung study as an example of real world data, and the REACT study as citizen science. As I said, cite the regulators and the policy documents. Small can be beautiful, and consider the editorial and reviewer perspective as well as your own author and reader perspective. And I'll stop there. Thank you very much.